All right, we're ready to start.
All right, well, thank you. Just to kind of introduce some of the topics that we'll be covering in the Q&A, I wanted to do just a brief introduction on some of the content that we're prepared to discuss. This specifically is meant to be a question and answer about the CCBHC expansion grants that SAMHSA has released. This would be, I think, about the 6th year that they've been running them, maybe a little bit longer with some of the demonstrations. And generally, the grants split into 2 categories. We have planning, development, and implementation grants, which are intended for organizations that are not yet certified as CCBHCs and seeking to obtain that certification. And then we also have implementation and advancement grants, which are intended for organizations that already are certified as CCBHCs. And there will be some differences in the documentation and requirements for each of those grants. In terms of SAMHSA requirements that are laid out as part of the grant, there's a number of these that occur within the first year, and then we have some renewals and annual requirements thereafter. Within the first 4 months of the project, we're all expected to begin collecting our first program intakes. With this most recent round or cohort of funding, SAMHSA also required that we submit a sampling plan, and that sampling plan was required to show how we were going to collect a 10% random sample of individuals for SAMHSA's required performance measurement tool. They had, at the time they were using the NOMS, that's now switched to the support tool. And we were required to collect that from at least 10% of those enrolled in the CCBHC. At 5 months, around the 5-month mark, we also had to submit the non-compete continuation application, which is pretty standard, just a general application for our next year of funding. Within 6 months, we have the first 6-month progress report documenting our progress on the implementation of the project and progress towards our goals and objectives. We also have at 12 months, the CCBHC criteria attestation for the PDI grantees that have not yet met that criteria. We also had the annual project performance report and the annual federal financial report, which are due each year. And then thereafter, there are a number of different annual or different renewal timelines of documents that are required as part of the grant after that first year, which would include annual reports for our project performance report, federal financial report. We also report quality measures annually, which includes some aggregate numbers on screenings and outcomes. And then we have to submit annually a sustainability plan of how the grant is, or how the project is going to be continued after the close of the grant. And then finally, there's some ad hoc requirements for the national evaluation. Those will be dependent or probably different based on which cohort you're in. And so with that, we wanted to open it up for questions. These are just some areas that we have some additional slides to cover some content if any questions come up related to these, but don't feel like you have to stick to this content. And feel free to drop your questions in the chat or to just jump in with any questions that you have.
All right, Rebecca, looks like you got your hand up.
Yeah, so because I focus so much on NOMS, and I think we have a great process for it. As I was saying, we use a lot of college undergrad interns. I'm just curious what others do for best practices, how you really get that client to want to do it, how you get the buy-in maybe from their, in a wishful world, I would love every case manager to cooperate and maybe help us get that client to participate because they're knowing and trusting their main person. But that doesn't always happen. So just wondering how others do NOMS to actually get them completed with good data.
That is a great question. That's one of the biggest headaches we hear. I'll let William and Kevin talk to that, but I'm also going to send out a poll quickly, but you got this?
Yeah, so a couple of things that we're seeing clinicians do to try and make sure that those are collected. Number one is offering incentives, especially around the follow-up surveys. For those of you who aren't familiar with SAMHSA's process, with the NOMS tool that is being retired, They required that we have a follow-up at 6 months for every client that completed an intake. And that's where some of the challenge is, because they expected us to keep the rate of follow-ups at close to 80%, which is challenging when you have individuals dropping out of services or other things like that. Some people would write in small incentives, say $25 gift cards or something like that, to try and get more people to complete those surveys. Another strategy that we've seen used is they're actually pulling or sort of organizing their schedules around when clients have to come in for other reasons, and as opposed to doing phone calls afterwards. And oftentimes, if the client's already there, they're already doing some of the other forms or doing some other things at the clinic, then it's a little bit easier to get them to agree to also do one of the interviews. A change that is occurring with the support tool, different than the NOMS, is the NOMS was required to be collected directly from clients in its entirety. The support is broken into two pieces. We have an A and a C portion. The A portion is intended to be collected administratively. So it's intended to be primarily pulled from your internal health records. And only the part C, which is a much shorter survey, is collected directly from the clients. That helps a little bit, because even if you're unable to get a hold of the client, for example, at 6 months, you can still complete the A portion based on your internal records. And in the C, since it's a shorter survey, it might be easier at their next appointment or something like that to get them to agree to fill that out. Or even if you do it over the phone, being able to collect that in a shorter period of time. It's not such a huge commitment, whereas the NOMS took about 30 minutes to complete.
Thank you.
Something I would add as well is there's also been a bit of change as to, with the support tool, how you're supposed to manage refusal. So in the scenario where you try and incentivize, you try and get these workflows in place, and it just doesn't work out, you can't get a hold of the client, or they just do not consent to the interview, especially with the implementation of support A, which is the administrative portion, SAMHSA is a bit more forgiving with if say a reassessment can't be done or the like, because their thoughts are you should be able to do the support A no matter what, since you can do that without the client interview. So that helps in some sense with the, say, for example, just getting the client's basic information in, counting towards your reassessment rate. And you do have to make sure that you have the proper system in place to track the information that the support A requires, though. A lot of it is like pretty similar to the NOMS legacy content. There's some things that have been taken out, like functioning scales and the like. It is less. The only thing that's more complicated about it is there's a lot of different versions depending on the age of the person you're interviewing, whether you're interviewing the client directly or if it's a child, whether it's their caregiver, so on and so forth. So those are also considerations you need to take in place, where if you're interviewing a child or you're running an intake for a child, how you work with families to get those interviews conducted as well versus directly with the client. But a lot of what Will suggested about incentivization and how clinicians are currently approaching NOMS interviews will be applicable moving forward.
Awesome answers, you guys. We have another question. It's, do you anticipate that CCBHCs with an expiring IA grant can apply for the next IA grant coming out in May?
Are you referring to an expiring grant that's expiring in October? Because if so, if it expires this year, then yes, you would be eligible to apply.
Yes, it expires in, my understanding is September of this year.
Yes. So the biggest thing that SAMHSA would restrict funding for is overlapping funding periods. But the new grants are expected to start in October, and the old ones would expire in September, so that will not be an issue.
Thank you.
All right, so we sent out a poll just asking it, what's your biggest challenge? And the overwhelming response was knowing who can qualify for this and navigating the application process. Would you guys like to speak to that?
Sure. In terms of the actual applications, that's something that REA can assist with, putting together narrative portions or anything like that. I'm sorry? I thought someone was chiming in. But anyway, the narrative portions, typically there is a series of required and allowable activities that we have to respond to, documenting your ability to meet the CCBHC certification criteria. And that's really the biggest component of it. Is there's several expanded areas of services that have to be implemented as part of the CCBHC. And you want to ensure that you're able to implement that. We did set up a shared drive, which the link is here. We can share this with everyone who's here today. And in that shared drive, Kevin, can you confirm for me, do we have a copy of the previous NOFO that was released for this
I
last
have
meeting?
not added that, but I can add that easily. And that would be relevant to, we have applications. It would be both for PDI and IA grants for, I believe it would be 2023 or 2022. I can't remember which.
2022 was the
2022, yeah.
when those were released. But I would recommend reading through those required activities and looking at the explicit expectations for the CCBHC services. If any of those are going to be difficult or impossible for you to implement, the application is going to require that you put your plan in place for how you're going to complete each of those. And so that's something that I would encourage you to consider and determine whether your specific clinic is able to meet all of those required services. And
do you want to review the criteria?
Sure, we can jump in there. Kevin, do you want to cover the criteria?
Sure.
And Maggie?
So I'll lead out with discussing just generally. First off, there's an overall process depending on whether you are a new PDI grantee or an already certified as grantee that's going for the implementation and expansion part of it. So if you're brand new, then what's going to happen is there is a full manual with a list of criteria in different sections, and we have that link where you have to go through and your organization has to meet each specified criteria as they're applicable to you. And SAMHSA gives you a year from project start to meet these criteria to the best of your ability. They recognize that some of these do take significant effort to get 100% in place, but they want you to meet as much as humanly possible by the end of your first project year, at which point you will submit an attestation either saying, yes, we have finished this, we are compliant in this way, this way, and this way. Or if there's any you have not met, you will say, we are in progress or on our way to meeting this criteria. Here are the steps that are being taken, in which case you will have to file a follow-up attestation with an updated once you are completely compliant. And if you're an IA grantee, then that's going to be part of your application, where the idea is you should already be compliant, although because these criteria to remain compliant must be renewed every 3 years. If there is a case where you were a grantee a long time ago, let's say more than 3 years, they technically released a revised edition of these criteria in March 2023, if I'm remembering correctly. So technically, everyone that's currently compliant must be abiding by those new criteria released at that time, which means if you're currently compliant, then it hasn't been 3 years, or you're just now hitting 3 years, and you would just have to submit a renewed attestation saying that you are still abiding by all those same updated criteria. So as for, and if you could go to the next slide, Will. There's a lot of different sections within those criteria, but there's also individual plans that need to be submitted that relate to specific criteria. So I think Maggie would be better suited to discuss some of these because she was heavily involved in the process for getting her organization certified as a PDI grantee, and can attest to some of the different items that had to be completed before the end of her first project year.
Yeah, I'm actually currently in the process of doing our newest community needs assessment, but that's something that's due within your first year, and that one we actually wrote in a contractor for, so that's always an option to have an external partner write. We chose an organizational psychologist, and it was a great community needs assessment, but I think a lesson learned there is that the people who know your organization best are going to be the people on the ground doing the work. That process, there's a very extensive toolkit that's put out by the National Council of Mental Wellbeing that's really helpful. It helps you with some scripts that you can use for a council of people with lived experience, or if you use your board for that requirement, it could be also them. We also survey our staff, our clientele on a quarterly basis, but our staff on a regular annual basis, our stakeholders on an annual basis. And that's really what you're going to use for that community needs assessment. That one is one of the quickest deliverables from when you start and are awarded for the project as well. And then for the staffing plan and the training plan, that's something that's going to be an attachment for your attestation. The staffing plan, in the criteria, it pretty much lays out for you what you're going to expect for that, because you're going to want to hire a medical director, but there's 4 different ways you can meet the medical director expectation. Arrowleaf is in a very rural area, so we use a psychiatrist who has consultation available for substance use disorders. Like I said, there's 4 different ways to meet that criteria. It's very flexible. SAMHSA is very flexible as well. But the staffing plan is very much just going to be what type of staffing setup you have at your agency, how many people are employed, how many people work in behavioral health, specifically in your CCBHC clinic. And then you'll want to keep track of credentialing like CADCs or trauma-focused certified, or the TFCBT. So that's like a specific qualification for people who do trauma services for youth. Those are things that you're going to want to make sure your HR department has in place so that it's easy to report on when it's needed. And then the training plan, again, is very clearly spelt out what type of training requirements there are for the criteria. Something very particular that they require is training on culture among veterans. So that's something that you'll want to also consider. We use a platform called Relias, which I know a lot of mental health centers also use. Relias pretty much has a CCBHC fitting training for all of the requirements that are laid out. For the training plan, I think what we did was just to spell out each of the required areas, like the person-centered care, and then we wrote in how we meet that deliverable, whether it's an in-person training, which our staff prefer 10 times out of 10, or if it's a Relias training that they get with onboarding and then at a regular interval afterwards. And then for continuity of operations and the disaster plan, that was, in my experience at the clinical level implementation, was one of the easiest lifts because we have an IT and a safety department. So really what we did with that was just revise existing material, which I feel like a lot of people who apply for CCBHC funding already have a solid infrastructure in place. And that's something that we kind of relied on a lot. So our continuity plan was basically just making sure that our clients knew that services weren't accessible if we had a snow day or if there was a natural disaster that caused a disruption for any reason. But really a lot of what my preparation was for the continuity of operations was making sure that clients still had access to intake and to crisis. So for me, that was just making a paper copy that's available in every single office, that all of our crisis workers have a copy of a paper version. So that way services continued and the client was disrupted in the minimal way. And then for the CQI plan, the continuous quality improvement, I believe that most people who are going to be a CCBHC are probably also going to be credentialed by CARV. And the way that I've made our CQI plan was that it has the quality assurance utilization review, but it also uses the quality measures that are spelled out in the criteria as well. So really what they want to know is how you collected the data, what the data shows you, if there's any trends that are saying that you need to have a corrective action in place. Like, for example, with our iServe measure, which is a quality measure, we completely redid our intake triage process because of what our CQI plan showed us. It showed us that people weren't accessing services in a timely manner. So that was our way of kind of controlling where we went from here and how we made improvements. And then I do not have any familiarity with the transition plan, but those are, none of those that are on the screen right now have a template, but SAMHSA is very much allowing you to interpret the criteria in the way that it fits your agency the best. And then you can make improvements and recommendations based on those plans. So that's a lot of what those are.
Thanks, Maggie. And the transition plan specifically, I believe, Kevin, you can correct me if I'm wrong, that's required for individuals that that don't have the 51% of the board members being people with lived experience. They have to develop a plan for that.
Yep, that's correct. So there's a certain rule or criteria about one or two options of how you're representing people with lived experiences in your CCBHC. And one of the options is to have your advisory board or your leadership board at least 51% individuals either directly with lived experience or relatives and family of those with lived experience. And the transition plan is required if you're not currently there, but you have a plan to add more people to the board to meet that criteria. So in general, you're not going to need that unless you're already don't have a good system in place for having that representation in your board of directors, leadership, or primary advisory council that you're going to set up.
Getting back to the original question, essentially these criteria attestations, this is going to be what the bulk of your implementation is going to involve. You're going to need to demonstrate how you can meet this criteria if you're not already, or how you're going to maintain this criteria, or perhaps expand those services that are available. And that all needs to go in your original application. And you have to document how that will comply with the required activities of the award.
The other thing that was in the poll was concerns about documentation and reporting. Would you like to speak about that, William?
Sure. So for the specific reporting, there is the project performance reports, which Kevin is prepared to speak about. One thing I'll say before Kevin jumps in is just that all of this reporting requirements involves documentation that should come from both your goals and objectives and your implementation activities, and setting up regular meetings where those are being reviewed and you're discussing those on a regular basis. Gives you the documentation you need through meeting minutes, or if you have specific quantitative measures, having those ready and reviewed in those meetings, say on a monthly basis, will ensure that you have all that documentation in place for when that reporting comes around. And Kevin, if you want to jump in.
Sure thing. So PPR stands for Programmatic Progress Report. That's the acronym that SAMHSA uses to describe the annual reporting requirements that you have to do associated with just summarizing project progress, and specifically there is one exception to the annual bit. There is a 6-month programmatic progress report, only the first 6 months. So the idea is you get your awards, say you got your award for this year, you started on October 1st of 2026. Then you would have the 6-month report, which would happen on April, let me think. Yep. So starting from April 1st, 2027, you would have 90 days to get in a summary of the first 6 months of your project. Otherwise, from that point forward, it's all annual, and it goes by the same 90 days from the end of the year. So for your year one, as an example, that would be October 1st, 2027, and you would have essentially till the new year, December 31st, to get that report submitted, specifically in that scenario, December 31st of 2027. Keep in mind, and this is also like a nitpick detail, SAMHSA operates on days, not months. So that is something where it shouldn't be that big a concern if you're being timely and you're not last minuting. But understand that if you actually went for, say, December 31st, you would probably end up submitting late because that's not actually 90 days. Final note is if it's the last year of your project, so assume you get a 4-year grant, the very last programmatic report, you actually get 120 days to submit instead of 90. And also with the way they structure their final programmatic progress reports, it's not cumulative. Year one report covers year one content. Year two report covers year two content. And that last year four report, even though it's the final one, would only quote year four. So that being said, the way SAMHSA requires you to fill out these reports, they've actually just recently implemented a new template that uses Excel. And I'm going to be blunt with you. Excel is not great for written narrative reports. So there's a lot of difficulties we've encountered with using this. The biggest one being character limits. So when they ask you questions, say, for example, Section 2 staffing plan updates, where what challenges have you encountered in staffing the CCBHC? You're only given something like, say, 750 characters counting spaces. So there's times where you want to write out a lot, and then once you write it out, you go, oh, wow, I'm 250 characters over the limit. I need to shorten this down. So we've linked the template we've been given for official reporting purposes, and that will be available like once we share these slides at the end to look at and review the actual individual content. But in general, the idea is there's required activities that are specified in the NOFO for the original application. So when this grant gets released, they'll spell out the exact required activities you have to complete, whether you're PDI or IA, and allowable activities that you can say whether or not you're going to engage in. And then at the end of the year, you say, what progress have you made towards these? You're also going to pitch your own specific goals and objectives as part of your application. You report on those in the annual report. There's also like a lot of those plans that we were covering before. Those are going to have to be covered in the annual report. And you don't necessarily have to include a new copy with every report, but it's good to keep a rolling plan like just readily available. So that way, when you say, oh, the sustainability plan, yeah, we went ahead and reviewed that this year. And that is current as of August 1st of 2027. You don't have to submit it with your report, but it's good to have that on hand and ready. And beyond that, the only other thing I can say is they are actively improving, I guess is the best word to use, this template. But they're also making edits depending on, say, whether it be an HHS directive or an executive order where certain things get added, certain things get removed. So we're seeing some of that, especially with the current cohort. There's no telling what's going to be going on. So like October 1st, 2026 onward is what this current cohort would be starting with. So any of this is subject to change, but we at least have the materials for the current 2022 to 2026 cohort you can reference. And that's the programmatic progress report. The other one that you have to, for documentation that you need to submit on an annual basis is the federal financial report. That's a lot more detailed process that's pretty static. Like I'm pretty sure the guidance they shared is almost 20 years old and hasn't changed. It's very set in stone, handled by your financial team. Maggie might be able to speak on that more because we as evaluators, we tend to stay out of budget and we let the financial team handle this part of the documentation. Maggie, as a project director, works with that part of the team and might be able to speak more on that.
Something I'll just throw in there as well is the federal financial reports are not unique to CCBHCs or even the SAMHSA projects. That's a pretty standard report for any of these federal grants.
Yeah. The biggest thing that I would want to note is the carryover request. If you are in a community mental health center or a provider in general that has staffing shortages or experiences high turnover, it's really good to be on top of your carryover request and kind of know where you want to put it so that your GMS isn't asking questions. So we always put our federal, or in our FFR, we put our carryover expectation and our plan for carryover. So our comptroller does a lot of the heavy lifting on that. And then what I do as like a programmatic staff is just make sure that the funding is spent. And then I also just make sure that our finance department is completely aware when I know that our personnel line or our fringe line isn't going to be spent down. And I believe there's like a 25% limit on that as well before they require a budget revision.
Yes,
that is correct.
25%.
Yep. And there is a section in the PPR, like a brief section that asks if you had any significant changes greater than 25% to the budget, and they request you summarize it there, but it's not meant to be in detail like it would be in the FFR. And what was I going to say? Oh, as another note, the FFR covers expenses for that year, whereas the non-competing continuation application, if we can switch to that slide, is documentation you're required to submit in anticipation of next year's budget, where there's actually, like, if anything, it's a combination of the PPR and FFR where you both have to submit basically summarized PPR of project progress that you made at the time of the having to submit the non-competing continuation application. It's honestly kind of redundant with the PPR. So you'll, like, say, for example, you finish your year one PPR and you submit that, let's say December 21st, and that's within the 90-day deadline. Typically, you have to submit a non-compete continuation application within the first 4 months of every project year. So sometime around January, you're going to get an email from your GPO saying, hey, by the way, guys, you now have to get your year 2 non-compete in. So that's another documentation you have to submit, where you have to make sure all the forms you have, like the SF 424, 424A, project performance site location forms, like all those standard forms, you have to go through, make sure those are up to date as part of the non-competing continuation application. You have to submit an updated budget for the upcoming year. So instead of summarizing what you did the past year, like the FFR, you're saying, here's what we expect to spend in the upcoming year. And you also restate just information from the PPRs, like saying, here's what we got done with last year's budget. Here's what we anticipate we will get done with this upcoming year's budget. And that's not like the actual expenses, but saying like actual milestones programmatically you expect to achieve, like saying, oh, we had planned to introduce or revamp our mobile crisis care team in the first 4 months of year 2, stuff like that. So those are, I think, are the biggest reporting requirements, other than the only other we could call it documentation, but it's really, I would say, data reporting requirements is quality measures. So if we can go to that slide, you are required as a clinic, and specifically as a clinic, that is important to note, to collect certain measures called quality measures. And this was also specified in the criteria in the CQI plan. So given that, as a clinic and not a state, those are the 2 kinds of quality measures. There's state collected measures and there's clinic collected measures. You as a grantee are responsible for clinic collected measures. And If you're a PDI grantee, you're aiming for that. Part of your first year will be getting that infrastructure into your EHR system to even store and collect this data. And there's 5 measures. I'm not going to get into those like immediately in detail offhand. Best thing you can do is look at the technical manual, which we have linked. And the idea is you have these measures. They have their own separate Excel reporting template that you have to use where you enter in the data both at a basic level as well as stratified. So like, say, for example, iServe earlier was mentioned, where there's different sub-measures of that. So time, for example, from triage to first date of receiving services and the like. And you have to summarize those for a given, and this is the interesting one, calendar year. It's not fiscal year. So everything else we talked about, it goes by project/fiscal year. So October 1st of one year to September 30th of the next year, that's the federal fiscal year. Quality measures is the one exception where they expect you to start measuring some of this. Let's say you're a PDI grantee starting in October of 2026. I would imagine they would want you to start recording probably January 1st of 2028. I don't see them expecting you to have it up and ready within 2 months of January 1st, 2027. And then you record for the entire year, and then you report by the end of the next year. So this is just ongoing. You record the data, you make sure you're able to stratify it as well. So like say stratified by age, stratified by assigned sex at birth, things like that. And the manual, like it's a large, long manual, but they're very specific and detailed about what you have to do. So that's another form of just active data documentation you have to collect as a CCBHC grantee. And I think those are the main ones. I think we've covered most of those that we would refer to as documentation that you'll be responsible for, unless Will, Maggie, you can think of anything I neglected to cover.
No, the only other thing would be the support data entry, but that's a little different than the reporting.
Sure.
So this is a huge part of what stops people and organizations from getting these grants that could otherwise qualify for them is the reporting. Can you speak to that and how you can overcome that?
So in terms of kind of our approaches for reporting, a process that we have implemented for getting the data that's required for the project performance reports is we set up templates to track goals and objectives and any other quantitative or qualitative measures that we're using for those reports. And then we run monthly implementation work group meetings where we meet with each team. We discuss the progress on the goals and objectives, and we take notes, document kind of how things are going, any successes or challenges that they might be experiencing. And we collect those in meeting minutes and then share those out with everyone who participates in those meetings. And when it comes time to actually provide the information in those reports, we have all of that information that we've been collecting all along. We're not having to look back or check on what things were like a year ago because we have all the notes that we've been collecting ongoing. So that is our process that we use for the project performance reporting. For the quality measures in terms of implementing those within your EHR system, I know, Maggie, that's a process that Arrowleaf had to go through. Could you speak to the process that Arrowleaf went through getting those quality measures in place?
Yeah, absolutely. For us, our electronic health record is very customizable. It is called CareLogic by Qualifax. They also have a few others, Credible, InSync, that some other people on the call might have also used. They use the same background reporting structure. I think it's called Pentaho. And the Pentaho report is our electronic health record built us a ton of these reports beforehand. So they're very CCBHC friendly. However, every clinic does it differently. Every risk assessment looks different for every clinic. So for the iServe, for example, the way that you define first contact is pretty much, it's outlined in the specifications, but really that looks different for everyone. We have a whole intake triage process, but someone who doesn't have such a customizable EHR might just use the Columbia Suicide Rating Scale as their first point of contact in their risk assessment. So my biggest advice on that is to work with your electronic health record, and if they have a reporting software that they use, finding someone who specializes in that and writes other CCBHC reports has been completely invaluable to us. And then another part of making it less daunting is checking it on a quarterly basis, like you would with any other quality assurance or data requirement that you have from accrediting bodies. Because if you go the full year, you might not realize that the system that you built up is not actually working with what's happening and what your clinicians' workflows look like. So continuously checking into that is my biggest advice, and then working with your health record.
Awesome. Really good advice. So you're not in it alone. You've got an entire collaborative team. I'll send out another poll, but if there's any other questions, you've got another 14 minutes here. So feel free to ask us whatever questions you have about these grants.
I will also be sure to share the slides. One of the things just related to the last question is that SAMHSA is pretty clear on all of the criteria that they expect us to collect. And when you're putting together the unique portions of your grants, that'll be your goals and objectives. If you're thinking about how you're going to measure those and document your progress towards meeting those goals at the time of putting the application together, you can already anticipate or kind of already be thinking about your plan for ensuring that you can meet all of those data collection requirements. Thinking about looking at the support tool, for example, there might be some measures that you can pull from that to help you address some of the goals, setting up your outcomes that you're tracking for participants based on data that you're already required to collect for SAMHSA. Those kinds of strategic moves can help ensure that you don't set yourself up to have too lofty of goals or too lofty of expectations for your data collection. And be thinking more strategically about what you'll actually have access to already. And that can limit the burden of actually having to put together a plan for collecting all this data, because you're already thinking about that when putting those applications together.
All right. Do we have any last thoughts from our panelists on either applying for or maintaining your CCBHC certification and grant funding?
Well, something I'll say is Kevin is going to share, it looks like he already shared the link to the Google Drive, and we'll put in the previous NOFOs that were released as part of this cohort in 2022. I would encourage you to read through those and really think about, especially the required activities that are specified in those applications. It's most likely going to look very similar. And I think that ultimately, if you are strategizing about that now and putting your plan in place, you do get time. You have a year from the point of being funded to actually put that plan in place and get it implemented to ensure you meet all of that criteria. And SAMHSA is going to be prioritizing funding based on feasibility and need. So specifying really how becoming a CCBHC can help the service area that you're serving, and how it can meet an unmet need. For example, the expanded crisis or the expanded eligibility of who can get these services, those types of things, being able to highlight how getting this funding will strongly help your area. Those are priorities that SAMHSA has. And so being able to clearly spell that out is going to be crucial for having a competitive application.
I did notice a question in chat as well about recommendations for EHR systems. I feel Maggie would be best experienced to talk about that process and how Arrowleaf selected their EHR.
Yeah, I've actually used a few different in my experience. I've used one called CX360, which is very basic. And then Arrowleaf itself uses, like I was mentioning, CareLogic by Qualifax. I'll put a link to it in the chat. The thing that I like the most about CareLogic is that it is highly customizable, but they do have a lot of add-ons. The way we cover our add-ons is through our CCBHC federal budget. We cover a lot of the patient portal, which is they call a client engagement portal. It used to be called On-Call. And then we also have our admission discharge transfer, which is the way that we share our data with the local hospitals and how the local hospitals let us know if they have someone that we have on our roster going into the ER. So I really like using CareLogic because it's CCBHC friendly, but it also has a cohort as well that meets on a monthly basis and talks about how people collect NOMs, how they do their quality measures, resources for support. They sell their AI system so that you can use AI to write clinical notes as well. So that would be my recommendation simply because that's what I have the most experience in. But you're really going to want a customizable health record that is easy to work with when it comes to your reporting. Otherwise, you'll do a lot of things by hand, which is not ideal, but still doable and still manageable as long as you have the staffing available.
All right, I think if we don't have any other questions, that pretty much wraps up our question and answering for CCBHC grants. I want to thank our panelists and everyone who came out. We've got the link to schedule a one-on-one with William, and please email us or link up with REA Analytics if you have any questions. And I hope everyone has a wonderful day. Thank you for joining us.
Thanks, everyone.
Thanks all. Have a nice day.